Good evening. People are out there, right?
Yeah.
Just want to make sure. I spend most of my day having those conversations with patients and families who probably never thought they were going to be in that situation. It's never going to happen to me at 38 or 54 or 72 or even 93. And yet here we are. So two things that I really want to impress upon you. One, and we've heard it from both Barb Frey and Dr. Wolf, is to have those conversations. And I think we, in the medical complex, if I can put it that way, has really served, I think, to reduce decision making to interventions. You want to be intubated. You want to be resuscitated. You want a feeding tube. You want to be in a nursing home. And those might be great third or fourth questions. But the important question is, what kind of life do you want? What sort of life would you be satisfied with? Would you be happy with? Would you be willing to tolerate? So one of the things that I use with the residents is that we have to set some realistic goals, because medicine does not have a magic wand. We tended to make death a medical issue instead of recognizing that it's a life issue. And so we can't reduce everything to medical interventions. The second thing I want to say, and I am not a crime congressperson, I'm not a lawyer, nor do I play either one of those on TV. But I cringe at the notion when we talk about health care as a right. That's not because I don't believe that everyone should receive adequate health care. I believe they do. But the question that ethics raises, the ethics question, if you will, is how ought we to behave toward each other? And to answer that question is a moral obligation to provide health care to everyone. Now, folks, lawyers, congresspeople, politicians will argue about, well, who is everyone? And that's something that's beyond me. But if we talk about human beings in this place at this time, it's a moral obligation for us to behave in an appropriate way, and that might mean providing everyone with health care. The last thing is, when you have those conversations with your loved ones about what kind of life you want, yes, fill out the 5 wishes, fill out a durable power of attorney for health care, fill out a living will, because that's the only thing you can get your hands on. But believe me, the more you read those documents, they're wonderfly vague. They cannot express what is in your heart. So death is, and dying is just as much a heart matter as it is a mind matter, maybe even more. So make sure you have that conversation with the people that you care about and who care for you. It will make it so much easier. I'll tell you the people I sit across from who said, we never had that conversation. I don't know what to do. So it's the holiday season, whatever your holiday is, and most holidays are about gift giving, so give your loved ones a gift and tell them what sort of life you might want near the end.
Well, I come to the table as a nurse for 30 years in the Chicagoland area, 10 of which have been with Rainbow Hospice, providing end-of-life care. And what I find fascinating and encouraging and not unique, but in a sense unique in this healthcare reform era, is that we provide such a wonderful, quality-based, personal choice, dignity, respect, service, that you really could do that in the entire healthcare system, and you could do it as well as we do it. We accept people no matter what. You know, we're not going to turn our doors against anybody who comes to us We're going to provide the care that gives them the most comfort, the most dignity. We're going to hear what they have to say and listen to what they want and their choices, not our choices, but their choices. And all that can be done in the healthcare system as it stands, the bigger system, the bigger picture, not just end of life, but across the board. We can do it efficiently and fiscally responsibly. We take time to talk to families and talk to doctors and talk to staff to find out how things are going. Let's reevaluate it. Is the plan still the same as it was when we started? And I really think that could exist in the whole picture, in the big picture of healthcare today, not just in hospice care.
I don't know. Want to? Okay, first of all, thank you to Rainbow Hospice for allowing me to participate. I'm very excited to be here. What I hope to add to the panel, in their own right, very august and educated, is the component that has to deal with the people that you need to turn to. Education, the physicians themselves. Nobody is born a physician, nobody is born a nurse. They have to be educated, and it is relatively new to the medical profession to have this specialty of hospice and palliative medicine. Depending on who you look to, medicine has been around for at least 4,000 years, since the time of the Egyptians, and separated from mysticism as a science. That's a pretty long time. And when we talk about end of life, when we talk about the specifics of hospice, we're really only talking about officially, as far as the recognition from Medicare as a service, 1983. That's a short period of time. So there are whole generations of physicians that have never been formally considered the ins and outs of end-of-life care. And that's part of my responsibility for residents and medical students. The medical students at Midwestern, I'm the first clinician they're introduced to, and it's the first time that they are exposed to some of the details and what separates healthcare individuals involved in healthcare and the degree to which they need to consider ethics in the performance of their duties. It's very interesting that in the course of teaching, I will run into residents that were originally educated as physicians in another country. And often those countries have low socioeconomic standards. And when I inquire, the way I begin the discussion is if they were educated in another country and they're doing an American residency, what did your medical school, what did your training have to say about end of life? Quite frequently it's not a consideration. And it has nothing to do with the fact that there's perhaps no quality to the education they have. But it's not a consideration because it doesn't have to be. If you are in rural India, there's no decision to make about a ventilator because there is no ventilator. There's no decision to make about who's going to care for this person because there's a persistence of extended family and circumstances built into the culture where it's a non-issue. And I frequently find that surprising when I compare American graduates to persons that had to live in that circumstance. And there's also seems to be an adjustment period that now that these resources are suddenly available to these individuals, there is quite a bit of angst in how is it now appropriate or not appropriate to use them. And that would be the experience that I hope to share with you.